Okay, so today we're going to be dealing with students with attention deficit hyperactivity disorder. So, some history related to ADHD. Well, we see that it was first described by a doctor in 1902, and we are seeing children with the same type of characteristics or symptoms as early as 1902, but we start to see in 1920 that we have children who have survived certain disease or disability, often exhibiting the same type of distractible and impulsive type behaviors that we identify with children with attention deficit hyperactivity disorder. And then we certainly have one of the most famous doctors, Dr. Charles Bradley, in the 1930s, starting to really study children that had these characteristics and using stimulants as medication. And we do know that many children with attention deficit hyperactivity disorder are prescribed medicines. And we are starting to use the terms more often in our fields of study. And we now only refer to children as having ADHD. ADD, or attention deficit disorder, is an old term, so you should not be seeing that, although you will, and you will still hear persons refer to children as having attention deficit disorder. We do not use that term anymore. So what is the definition? Well, there's some really important things to remember. We have to see a pervasive pattern. So it's not just being inattentive at times, but a pervasive pattern of inattention, impulsivity, and or hyperactivity and impulsivity that is more frequent and severe than is typically observed. So again, it's pattern and more severe. There are three types of attention deficit hyperactivity disorder. Children who are predominantly inattentive, some that are both hyperactive and impulsive, and some that are combined, both inattentive and hyperactive and impulsive. The prevalence, meaning the numbers in our population, we see a number of things that are important. First of all, we know that boys are more often identified with ADHD than girls. There's no difference in race. Caucasian children are more likely to receive medication, so you need to think about why that might be. And 3 to 5% of the population, or 3 to 7% of children, have the diagnosis of ADHD. What are the causes? Well, just like in other disabilities, there are physiological causes. So we do see generations of families of people who have the symptoms, characteristics of ADHD. We have noted differences in the brain of children with ADHD. There are environmental causes such as lead poisoning, and we know that in particularly older cities and in older homes, when lead-based paint was still allowed to be used, the paint chips crack off and children are breathing in the lead. We also know that there's lead in the soil. And smoking and alcohol consumption are environmental causes. The cognitive characteristics of children, what are we seeing in the classroom? Well, certainly problems in the area of their executive functioning. So executive functioning, think of things like memory. So their child's memory is not always efficient. Self-directed speech, meaning the strategies we use, such as self-directed speech, is not utilized effectively. They have difficulty controlling their emotions, so we might see outbursts, or difficulty controlling motivation or having motivation. And in planning, in the area of reconstitution or planning, the ability to break down what is observed and to combine parts to carry out new actions. So think of planning and problem solving. Academic characteristics, some students can be really successful academically. Others are consistently achieving below their potential. And a lot of times, a child's self-concept may be impacted as a result of having ADHD. In their area of social, emotional, or behavior, sometimes this child's self-esteem is really impacted. They might have difficulty developing and maintaining friendships, and this might be due to some of the behaviors that they have. And a lot of times you'll see rejection by peers. In the area of behavior, a lot of times they do not attend to detail, and you know that particularly our math teachers, you need to be persistent and paying attention to detail, but certainly in learning how to read as well. In anything academically, you have to pay attention to detail. They might be making careless mistakes. There is difficulty a lot in their failure to complete schoolwork and homework. They might not be able to listen effectively to reminders and directions from the teacher. There's difficulty organizing tasks and materials potentially, and that's important when, excuse me, we're completing assignments. And there might be complete avoidance of tasks that required sustained, persistent mental effort. A lot of times we'll see that children with ADHD are comorbid, it's called, meaning they have multiple disabilities. And they occur with such disabilities as learning disabilities, emotional disturbance, autism, traumatic brain injury, any of our psychiatric disorders, sleep disorders, and substance abuse problems. And we know that sometimes the medications children receive impact their sleep. Sometimes, because of the pain they experience due to this, they try to self-medicate, so thus substance abuse problems. Who has to make a child eligible? Sometimes it's just the school, but not in the case of ADHD. A lot of the times the referrals come from the classroom teacher, come from a general ed teacher or a special ed teacher, but a doctor needs to be the one who gives the final diagnosis. So a lot of times it's a pediatrician or a family doctor or a psychiatrist. The diagnosis may occur before the child enters the school, because we are seeing children as young as toddlers being diagnosed with ADHD, and that's actually a controversy. Should we be diagnosing children that young with ADHD? How do we assess? Well, certainly the medical, we've already said, is needed. But teachers are doing continuous testing in schools. There's parent rating scales. We send home parent rating scales and checklists around behavior. There's teacher rating scales and checklists. We look at samples of students' work, and as well as observational or anecdotal information. A lot of times we'll see our gifted children maybe also having ADHD or being assumed to have ADHD, because some of the characteristics we'll see in gifted children, and you'll have that later on in the semester where you look at gifted children more intently. But some of the characteristics of gifted children we also see in children with ADHD. For example, gifted students might have poor sustained attention in a certain area. But the difference is that a lot of times gifted students are bored. But in children with ADHD, the difficulty comes in most situations in terms of their attention. Impulsivity. Sometimes our children that are gifted at their good judgment lags behind their intellectual development. So their intellectual development is very high, but their social and emotional is on par with children their same age. But this is a primary characteristic of some children with ADHD, that they're impulsive all the time. And problems with rules, and so that's important for the classroom. They might question the rules and create their own, because they don't know, why is a rule a rule? But for children with ADHD, a lot of times it's due to the inability to regulate their behavior. So the Individual Disabilities Education Act is important. You cannot have, and this is important to remember, an ADHD category alone. So if you look at the categories of disability, you don't see ADHD. But why is that? Well, they are served under IDEA in the category of other health impairment if they need specially designed instruction. But a lot of our students with ADHD are served in what's called a Section 504 plan, or a service agreement plan, which is very different from an IEP. the Section 504 plan allows for accommodations to the general education. So what accommodations does the child need to be successful in general ed? Where we know if you have ADHD under the Individuals with Disabilities Education Act, you have an IEP and you receive specially designed instruction. So the questions here is, does the ADHD rise to the level where it adversely affects the student's educational performance? If it does, the child will receive an IEP under other health impairment, but not all students are eligible for that. In early childhood, as I said, we may see some toddlers being diagnosed. That's controversial, but we do see toddlers with severe hyperactivity, and certainly intervention will be crucial then. They might need a highly structured daycare environment and structure within their homes. At the elementary and secondary level, we have professionals collaborating in their multidisciplinary team to design effective techniques for students with attention deficit hyperactivity disorder. In transition and adulthood, 66% of students with ADHD continue to have this disorder, so it's not like it is fixed or it automatically goes away. What we see here is that they continue to have to hopefully have learned skills to help them to organize themselves, to deal with their impulsivity, and to deal with their work skills. They have to have a clear understanding of their disorder. So they need to learn about what is ADHD. They need to advocate for themselves and learn how to do what is needed to be successful. Medication is most clearly effective, is one of the most effective interventions, even though, again, it's controversial, right? Why is it controversial? Because we don't have enough studies, longitudinal studies on the use of medication. Prescribing medication to children when the brain is still developing. So the decision to prescribe medication, sometimes, children will be given medication just in the school so that they can pay attention. And then parents will say, well, at home and during the weekend, we don't give our child the medication. But it is seen to be helpful for many children for them to be successful in a school and work environment. But it's not sufficient to improve academic performance. Students still need a lot of strategy, instruction, and help in academic performance. So what are the recommended educational practices? Well, we need to be educating parents and educators on what is ADHD, how to effectively deal with it in the various settings. Environmental supports for students. A lot of times these children are on behavior intervention plans that deal with rewards and such as token economy systems, and how to deal with strategies and instructional interventions as well. We need to have realistic expectations of parents. It's not necessarily a parent's fault that the child is inattentive or impulsive. A lot of times we blame parents for children having a disability. Encourage parents, though, to be supportive and to be good role models and help them have realistic expectations of their child and make related resources available. What are the resources? The educational resources as well as community resources. What are the trends and issues affecting the field? So we look at, what happens to the child after leaving the school setting when they become adults. How should we be identifying adolescents and adults? If they've gotten that far in their schooling, should we give them a diagnosis at that point? So transition planning is critical. And for young children with ADHD, we have the ethical and professional dilemmas around a number of things, certainly early diagnosis and also medication. So what do we know about ADHD for sure? We know that no single approach is more effective than one another. Many factors and child characteristics affect the outcomes, so children will all be impacted differently. Predicting long-term benefit of treatment is very challenging. Long-term perspective on treatment, though, is needed. And educators need to stay abreast of research-based or evidence-based practices to help students with their potential. And that takes us through Chapter 6.